So let's start with the bundle branch block. So before understanding bundle branch blocks, we will just revise a few concepts and we will add one basic concept in terms of RV progression. So let's revise with the conduction. So conduction started from SN node to AV node to bundle of His, and from bundle of His there are two things, that is left bundle branch and right bundle branch. As discussed earlier, we know that left bundle branch is short and first to depolarize. On the other hand, RBB is very long and have longer refractory time compared to left bundle. So the left bundle branch will depolarizes right bundle branch. Okay, I hope we are clear with up to this. Next we will learn about R-wave progression. So this is your midline. This is our front. Okay, now this is orientation of your heart. Okay, this is your left ventricle, this is your right ventricle, this is your left hand, this is your right side, this is left side, right side. So one thing you must understand, the flow of current and the deflection in the ECG. Whenever there is a flow towards lead, whichever lead, then it shows positive deflection, and whenever there is a flow away from lead, we will get negative deflection. Okay, so this is our body. We know that whenever we go for ECG, there are precaudal leads, that is V1, V2, V3, V4, V5 and V6. So this is our orientations. Now let's understand, suppose this is your left bundle, this is your right bundle. So what is happening here? First, the left bundle is being depolarizes, then it will depolarize the right one. So can I say that the direction is like this, right? Also LBB to right bundle branch. So can I say this is the direction? Can I say this direction is towards V1, right? So similarly, can I say the direction is away from V6, right? So it is from away from V6 and towards the V1. So what will we get in the V1? So in V1 we will get slight positive deflection, and in V6 we will get negative deflection. Now what we will get the next? See, the left ventricle is larger than right ventricle, right? So leads that are placed towards left ventricle, leads that are placed towards left ventricle will show positive deflection, and from right ventricle it will show negative deflection. Now why it is? Since the depolarization happening everywhere, but LV is large So maximum current flow will be taken as towards left side. Thus, see, during the ventricular depolarization, this is the ventricular depolarization, and everywhere is starting towards left. So in V6 we will get the positive deflection. And what about the V1? It is away from V1, so we will get the negative deflection. So this is the main features of V1 and V6. So let's assume that V1 to V6, if we are traveling through like this, there must be some intermediate or some middle point. So the middle point is V3, where there is equal on both sides. I hope you got this point. Now let's start with LBB pattern. So what are the features of LBB pattern we notice in ECG? The first one is absent Q wave. Second one is broad QRS complex. Third one is deep S wave in V1, V2. And the fourth one is broad and tall R wave, which can be notched. No. Let's assume this is bundle of hairs. This is your left bundle branch. This is your right bundle branch. Right bundle branch. Normally, you know that left bundle branch depolarizes first and it will depolarizes RBB. So left bundle branch depolarizes right bundle branch normally. So this one is V1, this one is V6, the orientation of ECG leads. Now in left bundle branch block, there is a blockage at this side. So normal conduction of passing depolarization from left bundle branch to right bundle branch is not happening. So here RBB depolarizes first. So normally what we used to get in V1 is slight positive due to this and this. Now since there is a no depolarization from LBB to RBB, what we will get, there is a flat line, that is absent Q wave, and it will result like this. Similarly, what will happen to V6? We used to get initially positive, sorry, we used to get usually negative and then positive, but here we will get flat waves and this tall wave. Now this deep is S wave. Why do we call it as a deep S wave? We will see later. So I hope we have cleared with this first point, that is absent Q waves. Now second, that is broad QRS complex. Broad QRS complex. Now why do we get the broad QRS complex? Normally what happens, ventricles are depolarizes with neuronal conduction. But in LBB pattern, what does it happen is like this depolarization start with intermyocytic conduction. Now this intermyocytic conduction is very slow. So there is a longer time for ventricular depolarization. This will reflect in ECG as a broad QRS complex. So in V1 we will get broad and deep S wave. This is deep and broad. Why there is a deep S wave? Because the time required to ventricular depolarization is longer. So we get broad QRS complex and deep S wave. On the other hand, in V6, what we will get? Absent Q waves, and this is tall. So sometimes what we get in V6 is notched QRS complex. Now we have covered this all points. Broad QRS complex due to ventricular depolarization with the intermyocytic conduction. Deep S wave due to longer time, and broad R wave due to longer time. Now I hope we have covered with this all. This is the ECG of LBB patterns. You can say there is a absent Q waves. There is a absent Q waves. So now look into this QRS complex. This is broad QRS complex. What about deep S wave? This S wave is deep in V1 and V2. And what will we get in V6 and V5? That is a tall R wave. Tall R wave. As I told you that this tall R wave, sometimes we get notched. Okay. Now let's study why do we need to understand this LBB patterns. What is the significance of this LBB pattern? So significance of LBB patterns. Normally what happens? The ventricle and septum contracts in synchronously so that we can get a good amount of stroke volume and good output. What happens in LBB is there is a dysynchronicity in ventricular contraction. So septum contracts early and ventricular contracts late. So this results in decreased stroke volume and decreased cardiac output. So we get the cardiac symptoms in this patient. Again, I would like you to pay attention the more about the LBB patterns with respect to new onset LBB patterns. What happens? There are two things. That is a new onset LBB pattern, new onset LBB, and pre-existing one. Now, whenever there is an anterior wall MI or LAD occlusion, there is a higher chance that we will get the LBB pattern and not the routine ST elevation. But since it's a anterior wall MI, it is considered as STEMI equivalent. So new onset LBB always a STEMI equivalent, and there are few LBB that is a pre-existing. Suppose you have came across a patient complaining of chest pain, and you did the ECG, and you get the LBB pattern. So what will you do? Do you go for an angiography or PCI? Do you go for this intervention in every patient? The answer is no, because not every LBB is ACS. Some LBBs are pre-existing ones. So how to differentiate this new onset LBB and pre-existing LBB? So there was a scientist known as a Garboza. So he created a score called as a Garboza criteria, where a patient coming with the chest pain with the LBB pattern, we can differentiate that is whether it is a pre-existing one or a new onset LBB. So Garbosa criteria. So what did he propose? That there is a concordant ST elevation more than 1 mm. I will tell you what is the meaning of concordant and discordant. Okay. Then concordant ST depression more than 1 mm. Then third one is discordant ST elevation more than or equal to 5 mm. So what is concordant and what is discordant? So this is your Q wave, R wave. This is your, so this is Q, R, S and T. The R wave is positive, so an ST elevation is positive. So this is on the same direction. So this is concordant. Whenever there is a concordant ST elevation of 1 mm more than equal to 1 mm, then we will give 5 marks, 5 points. Okay. Similarly, concordant ST depression. Suppose this is your Q wave, this is R wave, this is your T wave. Just flip this ECG pattern. Q, R, S and T. So this is equal to or more than 1 mm. R wave and ST elevation in same direction. Okay. So concordant ST depression. So if there is a more than or equal to 1 mm in ST depression, concordant ST depression, then we will give him 3 points. Now what is discordant ST elevation? Now consider this is your Q wave, R wave and this is your ST wave. So Q, R, S and T. Now QRS complex is negative and ST elevation is positive. So whenever there is a more than 5 mm of ST elevation, then it is called as a discordant ST elevation. We will give 2 points. So total score is 5 plus 3 plus 2, that is 10. Score more than 7 or equal to 7 is considered as equivalent to STEMI. So what used to happen is that many patients coming with the chest pain with the new onset LBB, there were many patients that were missed with ACS. So the sensitivity for this Garbosa criteria was only 20 to 30%. That means there were high chances of ACS being missed. So Dr. Smith came with the modification of this Garbosa criteria, and this criteria known as modified Garbosa criteria. What did he propose? He proposed that whenever there is a concordant ST elevation more than or equal to 1 mm or concordant ST depression more than equal to 1 mm, or third point, discordant ST elevation more than or equal to 25% of deep S wave. So any of the above, if there is any of the above present, then we will call it as STEMI equivalent. Now let's study this on ECG. So consider this is the ECG of LBB, and let's try to fit this patient in modified Garbosa criteria. So we can say that there is a ST elevation, but that is not equal to 25% of deep S wave. So this is 1, 2, 3, 4, 5 boxes, and this is not even one box. So ST elevation is less than 25% of deep S wave. Okay. Similarly, there is no concordant ST elevation in any leads, or there is no concordant ST depression in any leads. So this is a new onset of LBB. So Dr. Smith modified this criteria to diagnose the LBB in ACS. What are the causes of LBB? The causes of LBB. So there are multiple causes. The first one is aortic stenosis, anterior wall MI, hypertension, hyperkalemia, digoxin toxicity, dilated cardiomyopathy. So these are the causes of LBB pattern. You can expect questions on LBB where you can be asked about this odd one out with giving 3 options. Also, you can be asked about the difference between the Garbosa and modified Garbosa. You can be asked about what is concordant and what is discordant. Also, you can be asked about the ECG, where they will give you ECG and they will ask you to diagnose. So these are the basic questions you can be asked. Also, they can ask this, the significance, like septum contracts early and ventricle contracts late. So these are the basic questions that can be asked in the exam. Let's move to right bundle branch block. Right bundle branch block. Now let's understand. This is our bundle of his. This is your left bundle branch. This is your right bundle branch. Here you have V1. Here you have V6. Normally, this is the route of depolarization, but since RB is blocked, so there will be no conduction and left ventricle will depolarize first. What exactly happens in RBB? So in RBB, left ventricle depolarizes first, so the contraction, then right ventricle contraction. Normally, suppose this is normal QRS complex. So this QRS complex, it is a simultaneous contraction of left ventricle and right ventricle. But since there is a no conduction from left bundle branch to right bundle branch, the left ventricle contracts first and then right ventricle. So what we get in ECG? Let's assume this is V1 and this is V6. So initially there is a flow of current from left to right, that is toward positive one. So we will get this positive. Similarly in V6 we will get negative. Okay. Now since the left ventricle depolarizes first, the current is towards V6. So in V6 we will get this sharp positive, and in V1 we will get negative. Now after left ventricular depolarization, right ventricular depolarization starts. So right depolarization, if right ventricular depolarization starts here, then the current flow is towards V1. So we will get positive V1 and then this negative. Similarly, what we will get here, there is a depolarization of right ventricle and the depolarization is with intermyocytic. So this will be broad QRS complex. This is SWF. So this is the ECG of right bundle branch block. I hope you have understand this basic concept. Let's revise again. So initially left bundle branch will depolarizes right bundle branch, but since there is a blockage, the V1 will notice normal positive deflection in V1, and about V6 it will get negative deflection. Now left ventricle depolarizes first and followed by right ventricular depolarization. So when the left ventricle depolarizes, the current will flow towards the V6. So we will get positive in V6 and we will get negative in V1. Next, right ventricular depolarization starts. So current flow towards V1. So we will get positive in V1 and negative in V6. Since the conduction is intermyocytic, so QRS will be broad and this will be the ECG. So just see, we can get this M pattern and here we can get W pattern. Please appreciate this ECG. In V1 this is RSR pattern and QRS pattern. So it is RSR pattern. Okay, so this is the ECG of right bundle branch block.